This presentation encompasses the case study of an infant who was diagnosed with a weak suck-swallow sequence and was referred for evaluation to speech-language pathologists. So our case study was an evaluation session of the 2-week-old male infant, and as I just mentioned, he was diagnosed with a weak suck-swallow sequence, and he demonstrated emerging behaviors indicative of failure to thrive. So failure to thrive is when an infant does not meet the expected standard rates of growth, and that growth includes both height and weight relative to other infants his age. And failure to thrive can be a result from premature birth and can result in decreased suck-swallow ratio and result in fatigue.
So this child might be referred to speech-language pathologists because we evaluate, diagnose, and treat dysphagia patients ranging from newborns to late adulthood, as well as facilitate the development of coordinated movements of the mouth, the respiratory and phonatory systems for communication and for oral feeding. SLPs are also qualified to use video fluoroscopy and endoscopic evaluations, which could be used with infancy and all the way through late adulthood as well. Dysphagia can be correlated to speech and language problems later in life, so those two together could be indicative, which is why we would want to deal with it with the 2-week-old.
So an evaluation consists of a case history, a physical exam, which includes the structure, function, and reflex to make sure there's no neurological impairment, observation of a typical meal, so how long does the meal last, instrumental exam when indicated, so such as the MBS, the posture and position of feeding, the respiratory status, the heart rate, the oral peripheral exam, so that includes the tongue and lip movement and strength, and the non-nutritive suckling exam, which is if the infant sucks on his thumb or not, if the infant is eating by mouth or not, so the PO or the NPO, the nutritive suckling exam, which is if the infant is suckling to get food, and the oral feeding guidelines, so by 1 to 2 weeks of age, an infant should be having 3 to 4 ounces of liquid for 20 to 30 minutes in 3 to 5 hour intervals. So the findings are decrease in weight, decrease in feeding time due to fatigue, immature patterns of nutritive suck and swallow. The ratio for suck to swallow should be 1 to 1 and 2 to 6 ounces per feeding. Since this infant has weak suck-swallow sequencing, his ratio may be closer to 3 to 1, and due to his inability to adequately suck, he may become fatigued quickly and therefore unlatch and stop feeding. It is possible that the infant spits the food back out, resulting in an absence of swallowing altogether. Normal feeding time should be between 20 to 30 minutes, 7 to 8 times a day.
So some possible causes of this infant's inabilities might be a developmental disability such as autism, Down syndrome, cerebral palsy, or a hearing loss. It could be a neurological disorder such as meningitis, encephalopathy, or traumatic brain injury, prematurity or a low birth weight, social, emotional, or environmental issues, which can involve the parent or the home life of the infant, whether or not the infant has siblings, any stress in the home, or if the infant is uncomfortable in any way. And then any structural abnormalities, which may include a cleft lip or palate, or a tongue tie.
So one thing that we want to remember before going into treatment recommendations is that we're going to be working with a lot of other professionals such as OT, nursing, dietitian. These are all going to be professionals that are going to work with SLPs as well to increase that feeding to make sure that they're getting that nutritional intake. So for SLPs, that overall goal is definitely going to be, like I said, to increase nutritional intake as measured by weight gain. We want to make sure that their weight is at the normal level for a child at their age. So some things to work on to reach this overall goal is to increase the muscle tone of the lips and the tongue by oral stimulation. So ways to do this oral stimulation could be using a gloved finger, because you want to make sure that it's all healthy, and to just kind of work our way around the mouth, so working with the tongue, the lips, the inside of their cheeks, as well as their hard and their soft palate, just kind of stimulating those structures to try and increase that muscle tone. Another thing that you could do is to strengthen the suck and swallow and decrease the fatigue by using a soft nipple. So this is going to decrease that fatigue by allowing more to come out, and then just having those oral structures be able to squeeze down on it. Another thing that you're going to want to do for sure is to educate the parents or the caregivers on what to look for at home in regards to feeding patterns and feeding strategies. So these feeding strategies could include making eye contact with the infant while you're feeding them, as well as repositioning to feed the infant, alternating the food temperature and texture, as well as thickening or thinning liquids. Another thing is to direct parents to take daily observations of the efficiency of the swallow. So this could be done by using a daily log of the observations. As infants mature, their swallow and their sucking abilities will naturally be changing and developing, so parents, like I said, should be closely observing this. Some factors that might impede these recommendations could include any comorbidities, so like the things that Alex was talking about earlier, as well as the cooperation of both the parents and or the infant.
Okay, and at this time, we would like to take time to pass out a handout for your reference about our case study and what our conclusions were and what the recommendations were for this specific infant. And we would like to open it up to questions from the audience.